Community Medicine Department, Mizoram Medical College. So we are moving on to the next session, Healthcare in Northeast. We would request Lieutenant General J.R. Mukherjee to please take the seat on the dais, and we have the panelists online with us. I would request my colleagues in the AV kiosk to give me a heads up if the session is ready for streaming. Thank you. We would request Lieutenant General J.R. Mukherjee, Member Emeritus, Governing Council, Center for East and Northeast Regional Studies, Kolkata, to please take the session forward.
Yeah. May I request all the panelists of the Northeastern India session to please turn on your videos and come on screen.
Hello, can you hear me?
Yeah. Hello.
Hello.
Is that Dr. Jain?
Yes, this is Dr. Jain here, General Mukherjee.
Yes, I can see. Thank you. And the other panelists? Dr. Sandra.
Yeah, I'm here. Hello.
How do you do, ma'am? And
thank you. Very well, thank you.
No, I think you said no, come and join.
Dr. Swati.
Hello, sir. Good afternoon.
Good afternoon. And Dr. Manoj?
Yes, sir, I'm here. Good afternoon.
Now, what I'm going to do is, if you'll forgive me, I'm not going to go through a normal introduction. Some of our speakers have to leave very quickly.
Yeah.
I'm going to come straight on to them, and whatever I have to say, I'll say in the end. I'll be speaking on medical tourism myself, but I'll talk about that in the end. I have only one request to the panelists. Please try and restrict yourself to 12 minutes. And secondly, at the moment, you are all from basically two states, Meghalaya and Mizoram. I will be putting in a little about Assam. If you could cover the other northeastern states also, please. That means Arunachal, Nagaland, Tripura, and Manipur. The first speaker would be Dr. Jain Rate, followed by Dr. Sandra. If we could start off straight on. Dr. Jain, over to you.
Thank you, Chairperson, General Mukherjee. It is an honor for me to be speaking in this session. My topic today is tobacco use in the northeast states of India and its economic impact. As the Oxford Dictionary says, tobacco is the only legally available consumer product which kills people when it is used entirely as intended. So I think my presentation is taking time. It is getting loaded. So in the meantime, I will go on with my presentation.
Dr. Jain, could you turn off the background, please? It's too bright. We can't see you clearly.
Okay.
The background light. You're still very dark.
Okay, we are trying to. Can you see the presentation now?
A little better.
Yeah.
Very slightly. We can't see the presentation yet.
You can't see the presentation?
No.
Okay. Just bear with us as we try and deal with the technology. Is it visible now?
The presentation is still not visible.
Okay. Yes, it's, I think, taking time to load. It's taking time to load online. Nevertheless, since my topic is on tobacco, and its use in the northeastern states of India, the 8 states, northeast, 7 states plus Sikkim, I would be making the presentation based on the Global Adult Tobacco Survey, which has been conducted twice. There were two rounds. First was in 2009 and 10, and the second was 2016 and 17. So the GATS has been conducted globally, all the countries, almost all the countries, and in India it has covered all the states and union territories. And about 70,000 to 74,000 is a sample size in both the surveys. So this has shown that as compared to the India average, in both the surveys, the northeastern states are extremely high in tobacco use, whether it is smoke form or smokeless form. In combined tobacco use, prevalence is extremely high, and we are above the national average. All the states of the northeast are above the national average. So that is something that needs to be noted. And if we see this, the prevalence, we can see that in both the surveys, okay, is that better for us?
Much better, much better.
Okay, all right. But I think my presentation is still not, is it there now?
No, not yet, Jane. You can carry on without it because
Yes,
both you and the next speaker are in a bit.
I'll carry on without my presentation, but eventually I hope it will load and we will send it online anyway.
That would be nice.
Yes. So if we see all the northeastern states, we see that the use is much higher in both Global Adult Tobacco Survey 1 as well as Global Adult Tobacco Survey 2. But as compared to GATS 1, there have been significant improvement in tobacco use, significant decrease in the states of Sikkim, especially. There's been dramatic decrease in Sikkim. Nagaland, Mizoram, and Meghalaya has seen significant decrease. There has not been significant change in the states of Arunachal Pradesh and Manipur. And in the states of Tripura and Assam, there has been an increase. Now, is my slide available? Visible?
Yes, it's come up now.
Ah, good, wonderful. Okay, so I'm on this slide. So as you can see, the increase is there in the states of Tripura and Assam. So I'm just talking about the northeastern states. Now, if we see the tobacco use, different types of tobacco use, you will see that smokeless tobacco use is extremely high in most of the northeastern states. India is there in capital, and you can see that it's much higher. And the smokers in Mizoram, we have the highest number of smokers. Smokeless tobacco, Tripura is very high. Dual Arunachal Pradesh is very high. But as we can see in the different type of tobacco, different types of tobacco, the prevalence is very high as compared to India, the India average. And the different commonly used tobacco products, the different types of tobacco which are commonly used as cigarettes, canny, bidi, betel quid, gutka, pan masala with tobacco. Then we have the oral tobacco application. In Mizoram, we have something called tuibur, that is a liquid tobacco. It's just a local form of tobacco, which is not much found in other states. So these are some of the tobacco products which are commonly used in Northeast India. Now, if you see the gender, the picture on the gender use, mostly females use less as compared to males, but in the states of Tripura, Mizoram, you can see that there's not too much of difference. Whereas in certain other states like Sikkim, there's quite a big gender gap. So this is something to show that we need to target our activities for the men. Now, tobacco use among minors less than 18 shows that in Mizoram, there are the minors who are using tobacco prevalence is quite high. It's the highest in the Northeast and in India. So smoking is more common as compared to the smokeless form. In Arunachal, the smokeless form is more. So this graph gives an idea about how we can target our intervention among the minors. Then this graph shows what is the mean age at which tobacco use initiation starts. So we can see that in Manipur, they start off later. Which is good. In the state of Sikkim, Arunachal Pradesh, they start off at a younger age, 15, 16 years old. So the campaigns have to be started at a younger age group in these states where the mean age of tobacco use initiation is low. And we need to target our children at a much younger age for it to become effective and to protect our children. Now, this shows the quit attempt which has been made by tobacco users. As we can see that not even 50% of the people who are using tobacco have made a quit attempt in the past 12 months. So I think as healthcare personnel and public health people, we need to see that we are able to motivate our tobacco users to at least make a quit, attempt to quit. And it has to be done so that we have higher number of people who make the quit attempt. This is the exposure to secondhand smoke, which is very alarming. As we can see, as compared to the rest of India, our exposure is very high. In Mizoram, it's very, very high at more than 80% at home. So that means our homes where the children and the infants and old people are staying, they have a high degree of secondhand smoke exposure in the workplaces, in public places. So this shows that we have to really take action regarding smoking in indoor spaces and try and enforce the laws in public places as well as workplaces. There are also a number of other non-tobacco products. As we can see, we have betel quid without tobacco, we have pan masala without tobacco, we have areca nuts. So the use of these non-tobacco products in Northeast India is very high. So besides tobacco, these are some of the other non-tobacco products that is a matter of concern, and we need to take action. I have just this one slide on the economics of tobacco use. I would just be focusing on cigarettes and bidis. As we can see, in the Northeast, the average that is spent per month by smokers is slightly less than 1,000 rupees. And for bidi smokers, it's about 350 in a month, which is almost comparable with the India figures. But this goes to show that a lot of money goes on cigarettes and bidis, and we're not talking about the smokeless form, again, where a huge expenditure is incurred. This is my last slide, which is the recommendation for Northeast India and also for the rest of India. These are some of the best practices from Mizoram. One is we need to have youth-related activities. In Mizoram, we have tobacco control chapters in school books. Then we have been advocating and setting up the TOFI, the tobacco-free educational institutions. We have a program called Himna Madad program, where we target not only tobacco, but the other drugs, substance of abuse. And this has taken off very well in Aizawl district. Then we also identified tobacco-free ambassadors from among some of the celebrities who are, have good following in the social media, and they do influence the youth. Second, very important recommendation is about enforcement, where COTPA, Cigarettes and Other Tobacco Products Act, need to be enforced. The various sections which deal with smoking in public places, secondhand smoke, sale to minors, then advertisement, promotion, etc., need to be enforced more vigorously. Then the Food Safety and Standard Act needs to be enforced. This is particularly important for gutka. Then the Juvenile Justice Act to protect children so that they cannot, so that they're protected against, from buying at a very young age. Packaging and Labeling Act is very important, especially for the tobacco contraband and other tobacco products which come in from elsewhere outside the country. Then the third is the political and bureaucratic commitment, which is very, very important in tobacco control. We need to set up the proper institutional framework, because without that, it's difficult to really implement a proper tobacco control program. Funding is important. Then setting up tobacco cessation centers and providing aids for cessation is very important. In Mizoram, all the districts have TCCs. And I think it's very important that in the Northeast also we set up more TCCs so that tobacco users would be able to access them for quitting. Then also promotion of tobacco-free villages, offices, workplaces, etc. have been done in Mizoram. We had even come out with an award called the Zamzo Award for smoke-free workplaces. We had measured them with the air quality monitor, and that helped in promoting smoke-free workplaces. Then we are the first state in India to have a dedicated day for anti-tobacco. This is on the 11th of September. So this is again one thing which highlights the commitment of the state. Then we are also point of sale board free state. We are the first state to be point of sale free. Then we have collaborated with NGOs and churches, and this has helped in having a good tobacco control initiative throughout the state. The tobacco contraband is a big issue for us because we are neighbors to Myanmar and Bangladesh, and we have a lot of tobacco contraband cigarettes coming in. And so this is a matter of concern for us. Tobacco industry interference, tobacco-based livelihood are some of the things that also we have been addressing in Mizoram. So I have just picked out some of the few things from Mizoram which I felt has worked and which I feel can be, can be of use to the neighboring states. So with that, I end my presentation. Let us choose life, not tobacco. Thank you so much.
Thank you very much, Dr. Jain. Very kind of you to agree to speak to us at such short notice.
My pleasure.
And we look forward to your joining us again. Over to Dr. Sandra now.
Thank you so much.
Dr. Jain, can you get off the screen share so that I can share my screen? All right. Sharing my screen. Sorry. Is my screen visible now?
Yes, ma'am.
All right. Just going to make it full screen.
The screen is visible.
Okay, just a minute. Sorry. Give me a minute, please. Okay. Right. Good afternoon, everyone. Is it on full screen or you're only seeing part of? Okay, let me just make it back to full screen. All right. So good afternoon, everyone. Can you see the full screen? Are we okay? Volume?
Yes.
You're okay? Yeah. Okay. So good afternoon, everyone, and greetings from the Indian Institute of Public Health in Shillong. We are a regional institute of public health. So I'm going to start by sharing a little story about a few weeks ago, I was in a training workshop for about 50 medical officers in Meghalaya. Remember that the medical officers are the leaders tasked with attending to primary healthcare in our country in the public health system. So I posed a question and said to them, as they're coming up in their career, suppose each of them is given 10 crores and asked to eradicate TB from their particular district or block, how would they spend it? And all of them provided highly medical, or as we call, biomedical responses that included increased number of doctors, increased HR, build more hospitals, improve treatment, supply drugs, and so on and so forth. So I wanted to just put across to you and use an example, and that's using the example of the UK to understand how a reduction in respiratory tuberculosis actually happened in the world. So just looking at a graph now. If you look at this graph, you will see that the rather dramatic reduction in TB over the decades in the UK, especially England and Wales, had almost nothing to do with vaccination or drugs in the initial period. In fact, if you look at it, the first anti-tuberculous drug came quite late on when the graph had steeply declined, and then later on the vaccination. So what's really going on here, and what happened? The answer would be in things like improved wages, important laws on water safety, on housing standards, on minimum wages, all of these which were enacted during this period. In other words, it's about policies and politics and public health. So moving on to another question. I said that I would address inequities in health. In our country, geography often determines health, or rather the inequities in health. So a child born in Kerala, for instance, has a much higher chance of survival than if it is born in, say, Assam or Meghalaya. And potentially there are many underlying associated factors which is contributing. And these figures are, by the way, from the National Family Health Survey, which has been recently released. Full reports are there, out now, and on complete and full of all of this available on the web. So if you look at, I'm just going to look at one particular point and focus on figures from Meghalaya, for instance, and you will see one particular factor that has been demonstrated repeatedly across time and place and geographies, and that is women's education. Something dramatic happens every time a woman, when women attain at least or achieve at least 10 years of schooling and pass the 10th class. There is a dramatic reduction in infant mortality, in neonatal mortality, and even underfed mortality. And this again is from the NFHS 5. So not really about medicines or treatments, but seems to have it's the wider determinants of health. I'm often asked, a question that I'm often asked is, what's the difference between public health and medicine? And is there a difference? So the response is often that public health addresses systemic factors that contribute to health. So what does that mean? Medicine is often considered as just a discipline in the multidisciplinary field of public health, and where medicine takes a very individual approach to health, as in, patient sits in front of you and you're finding out what's wrong and trying to treat that person. Public health looks at the community or groups or at the population and takes that approach. And often what we then find is there are things that we can as individuals do, but there are other things which also contribute enormously, which you don't completely have control over. And that's what we refer to as the determinants or the social determinants of health. And there are other factors which play in. I'm actually going to use a few examples from our work in Meghalaya and other states, and flag a few things. The next question is often, what do public health people do? So I'm going to try and give you a few pointers on what the work involves. I think you've heard quite a bit about COVID vaccines in the prior presentation or the earliest one of the speakers. And the point is, you may have the production ability, you may have great research, and it may lead to great vaccines. But all that is probably quite wasted if people don't accept it or take it. And so this is something that the government of Meghalaya had to face with, and I'm still continue to grapple with to some extent. And that's referred to as COVID vaccine hesitancy in Meghalaya. We were asked to try and understand what was happening and what could be the underlying reasons. And at that time, the East Khasi Hill district being largest population-wise and where the highest vaccine hesitancy was perceived, we did these studies using mix of methods, where we remember that the vaccines were first available to healthcare workers, noticed that there was higher hesitancy among healthcare workers, and then we looked at them and also looked at the community. So did quite a few things, and just going to give you, for example, in a few hospitals, we took representative hospitals from the private, from the charitable sector and public sector hospitals. And at that point, it was over 42% of the people, of healthcare workers, were resistant or had refused vaccines by our cutoff date. And just to tell you a little bit, give it a little bit of idea of what their reasons were. Of course, many of them were worried about side effects. They didn't think that sources of information was trustworthy enough. Social media, particularly WhatsApp, played a huge role in contributing to confusion and disbelief in information, and some of them chose to wait it out and thought they need more time. Surprisingly, quite a few of them had misinformation about vaccines' role in fertility and leading to impotence and other things. So all that, we found similar things even in different varied numbers, even in the community. The other thing, in low resource settings such as ours, often we do not have recourse to the very expensive medications that people often announce as beneficial. And in fact, COVID actually tells us something, showed us all the importance of research, because there were lots of medications that came to the fore, were publicized, and then when the big studies, which really looked at them in depth, were done, really there was nothing that really helps. But anyway, here was a situation when the second wave hit Meghalaya. The principal secretary had to take a call. What would we do to our more distant districts? How would we manage it? And we knew that there was a slight change in protocol in terms of switching over to higher dose antihistamines and high dose steroids. So one of the things that we did quickly was to do a real-time retrospective analysis of patients we're talking about serious COVID patients who were admitted in hospital, and we found that the new protocol did have some benefit in averting mortality or death. So we now go on to into training. Often in an attempt to redress the systemic problems which are nation's health systems, in 2017, the National Health Policy recommended the states to create a public health management cadre. The policy recognizes the multidisciplinary nature of public health and advocates for such trained personnel from varied backgrounds to be incorporated into the health system. So in response to that, IIP Shillong launched the first Masters in Public Health in the region. Just to say a few points, we use something called a continuous formative evaluation rather than end of term summative exams. And we do this because we know our students, indigenous or tribal students from the Northeast, they don't like exams, but that doesn't mean they do not mind assessments, and it's very important assessing and knowing what the outcome is. So the focus actually is that we place great emphasis on experiential learning, and that's of course based on sound theoretical underpinnings of adult learning. And we emphasize that learning outcomes and skill transfer is far more important than just giving good lectures. So just a little bit about that. But again, when on the aspect of producing healthcare resource personnel, or the health, human resources for health. One of the things that is curious in Meghalaya, and I think even in Assam, is that very few students from our +2 streams, in Meghalaya, if I take, when I did a quick analysis of our results, just 12 to 17% of our students get into science stream, and most of them go into arts. And you know that often this contributes to not just unemployed, but unemployable in various states. In more developed states, as a comparison, like Tamil Nadu, Kerala, Karnataka, Maharashtra, these numbers are often 70 to 85%. And I think Manipur is the only place which has got kind of numbers in the Northeast region. So what's the solution? And it was almost in response to the policy request from government that this year we launched a bachelor's in public health. Again, I think it's the first of its kind in the Northeast region, where we said that any student who's passed 12th standard in any stream we would take on board, this is actually tailored to the needs of the region, and we are trying to produce the future human resources for health that the state would definitely need. And what we do is, because they have no science background, many of them, we do a bridge course, which allows them to catch up on the essential science subjects. Just to give you as a point of I was asked to also say a little bit about other states, I guess. So we also have a regional resource hub for health economics, and basically what this center does is to do economic evaluations, or rather cost effectiveness evaluations, and looking at budgetary implications for health technologies, interventions, or even programs of the government. In fact, we analyzed the Meghalaya health insurance scheme, the first 3 phases of it, and have given recommendations in Meghalaya. But we also have studies in Manipur going on, where we are looking at the health benefit packages of Manipur, and looking at how best these can be. It's a costing study to understand the actual cost and what recommendations should therefore be made. In Assam, we know that there are areas which have timing deficiencies. So we're also looking at the cost effectiveness analysis of timing supplementation in pregnant women, so that we can reduce infant mortality rates. So that's ongoing. And new things are also happening. COVID-19 is not the only public health crisis that we're dealing with, nor will it be in the future. Almost every year there are communicable disease outbreaks in Meghalaya. I have all those ones in, like swine flu and Japanese encephalitis, scrub typhus, cryptosporidiosis, leptospirosis, brucellosis. These are all outbreaks that happen almost on a yearly basis in Meghalaya and in some of the other states in the Northeast too. So we have just been funded by the DPD Wellcome Trust India Alliance to set up a center for zoonotic and vector-borne disease, with the idea to do in-depth epidemiological as well as modeling of these diseases and to understand them better. So that's what's happening. Will be launched in January of next year, and we're all looking forward to that. And I think with that I will stop and allow a chance for questions if there are any. Thank you.
Thank you very much, Doctor. Very kind of you again to accept to speak to us at such short notice. And a pleasure meeting with you, even though it's only virtual. Next time I come to Shillong, I must try and look you up.
Sure.
Thank you very much, Dr. Sandhu.
Okay.
I'll do whatever summing up I have to do only in the end. But that was a wonderful talk, very educative. We'll now switch on to Dr. Swati. May I request Dr. Swati to please come online?
Uh, Good afternoon, sir. Can you enable us to share the screen?
Yes, by all means.
Are you able to see the screen, sir?
Yes.
Okay.
Yes, we can see the screen clearly.
Yeah. Thank you, Mukherjee, sir. Thank you very much for,
If you can make it full screen, please.
yeah, full screen. Just a moment, sir. Is it okay now?
Yes, it is. You can carry on.
Okay. Thank you so much, sir. Thank you for inviting us. And it's a great honor for us from Mizoram Medical College, the farthest state of Mizoram, where you have asked us to participate in this big event, which has been organized by Bengal Chamber of Commerce and Industry, with all the stalwarts speaking related to health in terms of inclusive growth. Today, I will be speaking about impact of COVID-19 in northeastern states. I'm not specifically trying to tell about the figures or graphs, but here I am trying to emphasize that what has been done in what has happened in last 2 years with my experience in Mizoram, working in Department of Community Medicine and working with the state government of Mizoram for controlling and combating COVID-19 pandemic over here. So the northeastern states with 7 sisters and the 8th one, that is Sikkim, it constitutes only 5% of the, less than 1% of the population in the country, and the smallest part of the country also. But it has a very natural diversity and it is also the gateway to the east of world, with all states having international borders. So a major state with all international connections. All the states got their statehood status during 70s and 80s. I would like to emphasize this because it has ultimately resulted in late or low or poor development what we are seeing over here. The difficult terrain with poor connectivity of roads and rail, the development is very slow. Though in recent 5 years, we have seen that Assam, the exceptionally biggest state in the northeastern region, has done fairly well. COVID pandemic grappled the world since the starting of year 2020 and is still continuing as a threat with mutant strain. Across the country, 30th January 2020, we know that the first case was detected, whereas in northeastern state, the first case was detected in the state of Manipur and Mizoram on 24th March. Most of the cases in northeastern state in year 2020 were detected among the standard population who came back to their native states after the national lockdown was called off after May 2020. The infrastructure development in terms of healthcare due to difficult terrain and sparse population, as I said, is very slow and in terms of poor. And this poor infrastructural vulnerability has exposed due to the COVID pandemic crisis. And initially, in the early 6 months of 2020, it resulted in lesser detection of COVID cases, though the whole states, the whole Northeast region, the state governments geared up for having more and more facilities for testing and managing the COVID patients. Till yesterday, that is 15 December, if you look at the cases, sorry for the small font, but if you see, Assam has the largest case. The largest state has cases which are around 6 lakhs, and second, we are standing, Mizoram is standing at the second number with 1,38,847 cases. Similarly, if you look at the graph which is showing about deaths due to COVID, again in terms of numbers, Assam is highest, followed by Manipur and Meghalaya. Even though the number of cases in Mizoram are high, still the case fatality rate is 0.37%. Now the emphasis over here, being representing Mizoram, I would like to emphasize here that the poor infrastructure and scarcity of health professional, we had to depend on the biggest state, that is our biggest sister, Assam state, and other developed states of the east and north, especially West Bengal, for diagnosis and tertiary care. But because of national lockdown, continued restrictions and access to tertiary health care, because our cases and the cases which were detected, the standard population which was coming back after May, the peak was seen in the later half of the year 2020. And that is the reason, with this all restrictions and all, and poor access to the tertiary healthcare, most of the communicable diseases like tuberculosis, HIV/AIDS, and non-communicable disease, the population which was suffering from this had a toll. And what we see is most of the mortality which is seen across the northeastern state is among those people who were already comorbid. Secondly, since it is a difficult terrain, already the primary healthcare services are very sparse because of the population density. On top of that, with lockdowns, containments, and diversion of the health worker force for tackling COVID at the major places, the regular primary healthcare preventive services like antenatal checkup, immunization, and nutritional supplementation were all hampered last year in 2020. And the most vulnerable population which bear the brunt was children and women, and has also resulted in decreased immunization coverage. We all know, and we have been talking since morning about health and inclusive growth. Health is a matter of state, and although all the states tried their level best in containing, because of the late development, because of the slow development and the resource constraint in terms of budget for health, the out-of-pocket expenditure during the COVID crisis among the population was very high, especially during the second surge of the cases, when the preparedness in terms of tertiary care for COVID management was not taken up at a larger scale, what we see in the developed states of the other part of the country, especially with the antiviral and newer drugs in the market, and also the intensive care which was required for hospitalized patients. Due to the diverse population in all these states, smaller population, small population densities, as well as the smaller areas, diverse population and ethnicities, the economy in Northeast region is mainly dependent on agriculture. But that has also not developed to such extent to create employment as well as export. In 2018, the Special Forum of Niti Aayog was created to accelerate the central government's effort, with a main objective to identify the constraints in a way of accelerated, inclusive, and sustainable growth of all the 8 states. After this announcement in 2018 and 2019, most of the schemes, most of the Niti Aayog achievements or Niti Aayog forum ministries which were involved and the partners which were involved, they tried to boost the economy in terms of agriculture in this particular region. But unfortunately, after 2019, that is from the starting of 2020, because of the pandemic crisis, this has led to an halt, especially in terms of lockdowns, schools, educational institutions being closed, containments, and market restrictions. This has all led to a slow progress in this inclusive growth, which has been the main objective of the special forum under the donor ministry. And the states are still struggling to provide healthcare and restoring to the normalcy amidst this, the greatest pandemic of the century, which has created so much of health, economic, and social crisis. renewed thirst to accelerate the growth in terms of infrastructure and connectivity in Northeast region is the need of the hour for further economic development. The pandemic crisis, even though there was a major setback to all the governments in Northeast region, the community participation for controlling the pandemic is a major achievement, along with the largest drive of vaccination against COVID through combined efforts of central government, state government, and local population. This particular pandemic has taught us that how we all can work together. The central government has been working hard and has been including all the northeastern region for development, but COVID has slowed down the pace of their work. The renewed thrust is what is required from the ministry in order to see to it the projects which are running, the projects which are already there in place in all the northeastern regions as a should gear up, should accelerate so that the inclusive growth for the development, economic development of the Northeast region can be taken up. That is what I wanted to emphasize when I talked about the COVID impact. And that's what is my plea to the whole government functionaries to look and bless the Northeastern region in this COVID pandemic as well as in future, so that we work and the development can be achieved through all sustained efforts. Thank you so much.
Thank you so much, Dr. Swati.
Thank you, sir.
Very kind of you again also to speak to us at such short notice.
Thank you, sir. Thank you so much for inviting us. Thank you.
And tell us so much about the COVID situation in the Northeast. I'll now request Dr. Manoj to kindly make his presentation.
Good afternoon, everyone. Thank you so much, sir, for giving us an opportunity actually to present our case. I think the topics in this session and most of the sessions are little crossovers, but we definitely would like to make the case of Northeast. Thank you so much, BCC&I, Bengal Chamber of Commerce. This is actually inclusive growth, I would say, where you are really giving us a space where we can share our thoughts, we can share our concerns and move forward. As Ma'am Sandra also said and Dr. Swati also said. Is my screen visible, sir?
It's absolutely clear. Go ahead.
Yes, so my presentation is just actually a theoretical concept which I would like to link to some of the concepts in the inclusive growth. And this I had been talking with UNICEF head office of India, and we did have a meeting in 2019 at Manipur of all the states of Northeast to look at the infant mortality, plight that the central government team, the Ministry of Health and Welfare, the Division of Child Health was there in Manipur to discuss the takeaways from the low infant mortality rate in Northeast. But I would say definitely, as both the earlier speaker talked about Northeast terrain being a little different, the situations are also different, and the way things work in Northeast are also a little different. Yeah. So yes, I start with a quotation from Mohandas Karamchand Gandhi. It is health that is the real wealth, and not pieces of gold and silver. I think what more inclusive statement would be here than this. Secondly, the IDRC definition globally is seen for an inclusive growth is, yes, growth that improves the access of the poor to expanding the economic opportunities and reducing inequality. We have been hearing inequality since morning and talking a lot of economic opportunities like this, where we all are sharing our thoughts and concerns and way forwards to bridge this gap of inequality with more and more economic opportunities. When we are talking about the infant mortality rate, we know as a medical scientist or medical physicians or doctors, that yes, this is one of the sensitive indicator of the community's development, infant mortality rate. And if you see the current trend, I've just picked up the states where the infant mortality has really gone down. Talking about and from the National Family Health Survey 4 to 5, and also the SRS 2019, which was just published in October 2021. If we look at the figures of Manipur, where the IMR was 22, then which increased to NFHS 5 to 25, and SRS showing the more improvement in 2019 towards 10. Talking about Mizoram, we had under the NFHS 4, it was 40. Then in NFHS 5, it is 21.3. And if you, it is a sharp decline to 3 in SRS 2019. Same goes for Nagaland, from 30 to 23 in NFHS 4 to 5, and SRS again sharp decline to 3. And unfortunately, if we equate, because we are talking about the economy, and if we talk about the below poverty line population, I thought I will compare these 3 states where we are already comparing IMR. If you see, Manipur has little higher population below poverty line, and if you talk, this is an RBI data of 2012, but being used extensively now also. So where the Indian below BPL line is around 21, population below poverty line is around 22%, whereas Manipur is almost 37%, Mizoram being 20, and Nagaland also at around 18.8 or approximately 19%. So we do still have this question, like, okay, 37% of Manipur population is below poverty line, but the access to healthcare is definitely evident from the declination of the IMR. Historically, we know to get this on board, to have a reduced IMR, we need to, there are multi-pronged approaches which we are looking at. So, because that talks about the child survival, and which is the most, as we know, that it can show a more amount of life expectancy in future. So multi-sectoral approaches, we know all that, and Ma'am Sandra also talked about that female education or mother's literacy, how it is linked. Along with that, I think the most important part we struggle is nutrition, because if because we have been badly compared for more than so many decades with sub-Saharan Africa. We talk about $1 trillion economy, and at the same time, where we are also having the half of the children, are malnourished children staying in this country. So this is a hypocrisy that we said we have achieved so much economically, but at the same time, that is not reflected in the action, or not seen in the ground level. Increasing use of health services, definitely for various efforts from from the Declaration of Health for All from 1978 till date, with MDGs and SDGs and NHM, NRHM, NUHM, and NHM. So these, and many programs on pregnancy and delivery outcomes, and also eliminating the gender gap of the child health services. We have been talking recently, all of us have been witnessing, okay, some paper publication, because we all are now learned from the WhatsApp University, that okay, Beti Bachao and Beti Padhao scheme, almost 2/3 of the money spent by central government has gone into only IEC campaign. But if you see, look back, people do have, as I think I heard Dr. Sarkar talking about information asymmetry. Yes, if the information asymmetry still exists in this country, we still need to be educated by these IEC campaigns. I don't think so if the money has gone into that. If that actually, if you see in NFHS 5, that has gone to show that our male to female ratio has improved. That's what is an achievement. And this is not a new idea, as we all know, all the seniors are here. This was, of course, to the world. India was talking about inclusive growth since 2004 under the 11th five-year plan, envisaging rapid growth and poverty reduction, employment challenges, access to essential services, social justice and empowerment, environmental sustainability, gender equity, governance, which is still important in day-to-day practice, components of, we have been hearing agricultural, watershed, infrastructure, especially if you all add these principles apply to Northeast, I think they are still valid when we are thinking of inclusive growth. And what are the hindrances which we look at economic growth? Robert Frost has nicely said, what to do? Problem is there. So the only way around is to go through. Yes, go to the rough. Yes, we have been dealing it. I think hats off to all state governments and central governments, as we have been also learning about the vaccine uptake by Dr. Niranjan Mishra was talking about our Odisha experience. Yes, the entire country came together to take us through this COVID pandemic. When we talk about IMR, and this is learned over so many decades, we have learned this, that IMR is the single age category mortality, peculiar set of disease and conditions it can take care of, but it's very quick and direct, specific to health programs when we are assessing the IMRs. So it is for the health status of the community, which will think of how the level of living, because we were talking of quality of life all throughout when we are private healthcare sector. I think level of living of the people can be attributed to IMR, and effectiveness of our maternal and child health services, which we are, whether it is in the private domain, whether it is in Sarkari domain, or we are talking about philanthropy, NGOs, whatever. And we can equate these to physical quality of life index. If we see, there was a paper a long back, I'll just show this little later. If it, yes, by Reed Path and Alote, which actually compared the disability adjusted life expectancy towards IMR, and the correlation was almost 0.9. Which means because that is a little complex indicator to look at disability adjusted life expectancy, but IMR is more easy to calculate. If we are able to show that IMR reduction is there, definitely there is a disability adjusted life years are there. So for what framework we look at when we are thinking of improving health, which will improve the economy, we know that the domestic economic growth has directly linked to the productivity, labor productivity, economic burden of the diseases. So, because we are talking about out-of-pocket expenditures, yes, definitely you improve health, you improve health system, you improve health care, you improve health awareness, that is definitely directly impacting on the sickness, absenteeism, and producing more labor productivity. Life expectancy correlation definitely positively correlates with the per capita government spending on the health, whether it is center or state combined together. Maternal mortality correlates negatively to the per capita, means if the maternal mortality is declined, then per capita government spending on the health is little increased, because a lot of schemes has to come in to motivate and channelize the maternal or to increase the efforts on the curbing the maternal mortality. Small increase in the public health expenditure we see that can drastically reduce the out-of-pocket expenditure. So it's in the macroeconomics and health publication where we learned the experience from the 191 countries that life expectancy and mortality rates are reliable health indicators which are responsible for approximately 1/3 of the economic growth. So it is evident from all the data which is there from the globe that if we take care of these two, life expectancy and mortality rate, eventually the economy increases. When we are thinking of way forward, how the inclusive growth we have to see labor productivity. We have to see how best we can save in health expenditures, increase productivity in this sector, increase attractiveness to the investment of human resources, incremental worker longevity, lower depreciation of the human capital investments, technological, since morning I'm hearing about technological innovations, and yes, that is the only way forward. Okay, because we learned in the COVID that yes, the technology made the world close, despite of, people talked about penetration of the internet. Yes, but if you see every child also from childhood till the medical schools, everybody is online. Rather than getting nothing, they're getting something. I think that is the technological innovation which the digital India is looking forward for. Improved environment for investment, market expansion. Yes, definitely. When we think about northeastern terrain, we need more and more market expansion. Infrastructure definitely are the need. We know this is a beautiful terrain of eight. What we say is not rather than 7 states, if we include Sikkim, 8 states, we have a lot of tourism opportunity to link. What are the drivers? If we increase the expectancy and mortality declination, tourism is the first choice for us in Northeast. Presence of unique ethnic cultural customs and traditions are also our drivers. Numerous states says this terrain is rich in bamboo, well-performing gender development indices. If you talk about Mizoram, had happiness index almost in first 3 states of the country. Handloom, weaving, good climate, abundance of this is known to all of us, but I just want to reiterate this, that if we take care of the health care, I think this we can concentrate on these sectors of natural resources, safe and clean, pollution-free environment. This is a beautiful document by FICCI on emerging Northeast India. They have done a wonderful SWOT analysis. If one wants to look into how it can impact on the health, this is a wonderful document. Another project which in Northeast done by the central government under the Ministry of Donor, with an objective is to improve the livelihood, because more we heard from everyone for Northeast is agricultural, flora fauna is beautiful. This livelihood, especially we want a woman centric. We want unemployed youths to join, and most disadvantaged population, especially those who are HIV, drug addiction. These all people needs help. Okay, so this is what is natural livelihood project is being done and being implemented in Mizoram, Nagaland, Sikkim, and Tripura. Somebody who wants to statistical modeling, I think this is yeah, just 1 minute, sir. So modeling effect of the health on the economic growth is you can see from WHO's paper. So finally, how do we strengthen then the healthcare to get this? Of course, the guru of UHC was there in the morning. Professor K. Srinath Reddy is always talking about universal health coverage. Yes, we have to do that and tackle information asymmetry, because that is eating up your OPP. For Northeast, the last message is focus more on skill, human resources and health. Quality healthcare is an issue. Tackling inequity, infrastructure in health, definitely new medical colleges, upgrading existing institution. Corporate sector involvement in the health is much needed. Public-private partnerships in health. People have to move from Assam to peripheral states also. Technological upgradation and innovation, more operational and implementational research in health is a need. Lastly, achievement of higher growth should be reflected in terms of quality of life of people. I think that's the take-home message. Thank you so much.
Thank you very much, Dr. Manoj.
Yes, sir.
That was an excellent presentation. Again, very kind of you to agree to speak to us at such short notice. Thank you on behalf of all of us.
Welcome, sir. Thank you. Thank you.
I'm going to take only 2 to 3 minutes. I'll speak primarily on health tourism. Now, it's very important as far as Bengal and Bengal Chamber is concerned. One of the basic issues laid down by the Prime Minister of India is the Act East policy. Now, as part of the Act East policy, the whole of the Northeast is treated as a gateway to Southeast Asia and the ASEAN countries. One of the best ways to do this is develop health infrastructure to the maximum possible and cater for health tourism from the neighboring countries, that is Bangladesh, Myanmar, Bhutan, Nepal. At the moment, health infrastructure, as also trained personnel, are sadly lacking all over the northeastern part of India, all over the northeast. At the moment, Guwahati has some percentage of the infrastructure, in fact, the highest percentage in the northeast, but still nowhere near satisfactory. Next is followed by Tripura. Next in sequence is Tripura, Agartala. But Agartala really is in a position to cater only for Bangladesh. As far as Mizoram is concerned, it is Mizoram and Manipur are best poised for Myanmar. So they need to develop the infrastructure there. Mizoram got a medical college just 1.5 years ago. Before that, they had no medical college. The whole of the Northeast has the highest degree of cancer in India, and for that matter, in the whole of Southeast Asia. And why? Because of tobacco, because of smoke. So there was a reason for bringing in the tobacco and the smoking part of the presentation today, because that has to be brought under control. Cancer is one of the most expensive diseases to deal with. I am a cancer patient only due to smoking.
Sir, would request you to kindly use the microphone. The online participants cannot hear you otherwise.
Okay. So all I'm trying to say, and I'm finishing off here, is that health infrastructure has to be improved. Automatically it will give employment and generate growth all over the Northeast. And it will bring in tourism from these neighboring countries, because there is negligible medical care in Myanmar, in eastern Bangladesh, or in Bhutan, or in Nepal. So that's a wonderful way to act east and develop it. Now, to sum up quickly, the first speaker, Dr. Jane Ralte, she spoke on the issues of tobacco and its harmfulness, and therefore how and why it needs to be brought under control. Dr. Sandra Albert from Meghalaya and Shillong spoke on public health issues and various issues related to public health and how they need to be improved. Dr. Swati spoke on the COVID-19 situation and how they handled it. But the fact remains is, due to lack of infrastructure, I know for a fact about Mizoram because I was there. And during the pandemic, it has one of the highest per capita rates of COVID in India. The same applied to Assam or Nagaland. But basically due to lack of infrastructure. Then Dr. Manoj spoke on the overall public health administration issues related to the North. I'll end with that. I must thank the panelists once again and express our gratitude on behalf of all of us sitting here. Thank you for enlightening people on the situation prevailing to the Northeast and how it can be improved to let the Act East policy move forward. Thank you.
Thank you, sir. I would now request Mr. Aniruddha Lahiri to please present a memento to Lieutenant General J.R. Mukherjee. To our speakers online, we will send the soft copies of the photographs of today's event. The framed photograph is being presented to Lieutenant General J.R. Mukherjee now. Ladies and gentlemen, you were requested to please join us for lunch at the Bengal. Join us for lunch at the Bengal Lounge. for those who are not acquainted with the geography of the